Hi, good evening, good afternoon, good morning, everybody. It's 6 p.m. in Paris, Brescia, 5 p.m. in London, noon in New York. A very warm welcome to all of you joining this new journal club brought to you by the International Academy for Clinical Hematology around the globe and across the hematology field. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And the uh, topic of our journal club today is actually related to CMV infections after allogeneic stem cell transplantation. And the ICH steering committee has selected this paper published a couple of days, I think, before Christmas, around 23rd of December, published in the Lancet Hematology by Dr. Domenico Russo and colleagues about the efficacy and safety of extended duration letermovir prophylaxis in recipient of hematopoietic stem cell transplantation at risk of cytomegalovirus infection, multi-center randomized, double-blind, placebo-controlled phase 3 trial. You can see here the summary of the study. So this is really a state-of-the-art randomized trial, which was performed in France, Germany, Italy, Japan, the UK, and the United States. And as we all know, letermovir is already approved for CMV prophylaxis in the context of allogeneic stem cell transplantation. And here, the authors actually tested against a placebo the possibility to extend the treatment duration from 100 days to 200 days. So they have included actually 255 patients, the screened patient for eligibility, and then 220 were randomly assigned either to letermovir or to placebo. And to make a long story short, actually, the trial reached its primary endpoint, which is about clinically significant CMV infection reduction in the experimental group. And obviously, the conclusion was that extending the duration of letermovir prophylaxis up to 200 days after transplant is effective and safe. So you can see here the design of the trial, really very nice design, a 2-to-1 randomization. So these are the figures, and here the primary endpoint, and I think we'll have the opportunity to discuss it, is about clinically significant CMV infection, which was significantly reduced in the experimental arm compared to the placebo arm. But it's also about the initiation of preemptive therapy for CMV based on documented CMV viremia, and there was the results were in favor of the experimental arm. And you can see here the shape of the figures when it comes to comparing these two groups, the cumulative rate of clinically significant CMV infection in the primary efficacy population. And these are the conclusions of the editors of the Lancet Hematology. And the conclusion is that extending the duration of letermovir prophylaxis to 200 days is a patient-centric, risk-adapted approach to letermovir prophylaxis for patients who remain at risk of late clinically significant CMV infection. And to discuss this nice paper, we have two distinguished guests, namely Professor Michele Malagola, who is an associate professor of hematology at the Brescia University in Italy, and who is a contributor to this nice study. Thank you, Michele, for joining us.
Thank you for inviting me.
And the other panelist is Dr. Antoine Cap, who is an assistant professor at the Sorbonne University here in Paris, in France. So as usual in the Journal Club, the first question is for you, Antoine. We usually ask the first question to the panelist who didn't participate to the study. And just to get quickly your overall impression when you saw this paper, was it a disappointment, or you were very excited about it, or you thought that was a very nice confirmation of something maybe we suspected and we thought in the transplant field is needed?
Thank you for inviting me. To be honest, the first time I read this paper, I had mixed feelings. First, I have to say that I'm convinced that letermovir is a great drug. It's well tolerated. It's efficient to prevent CMV infections in very high risk patients, like from day 0 to day 100, or even for patients suffering from acute GVHD disease. But we have to keep in mind that it's expensive drug. I think it's about $10,000 a month. So if we want to extend the duration of treatment, we have to ask for strong evidence. And I had mixed feelings because I have three remarks, if I can, three remarks on that paper. First, it's the definition of used for clinically significant CMV infection. They took onset of CMV end organ disease, so it's a good one, so it's a good endpoint, but it was also preemptive therapy, and it was mixed with just a clinician would decide to treat viremia, and the threshold used was quite low. It was 200 units per ml. So we just have to keep in mind that with that threshold, we will treat a lot of blips, especially after day 100. And the second point is that after stopping letermovir, so after 200 days, if you look at what is happening, you can see that there is no difference between the two groups in terms of CMV infections. So one could say that they just postponed the CMV reactivation. And thirdly, and maybe it's the more important thing, it's about patient selection. And if you apply the criteria of this paper, let's say, for example, in France, if you just take patients receiving ATG or mismatch unrelated donor or haploidentical donor, virtually you will treat everybody because of the wide use of ATG in Europe, So it's not a really restrictive use from my point of view for really costly treatment, but it's open to discussion.
Excellent. Thank you very much, Antoine. And actually, you brought some good points that we would like to discuss in more depth. So, Michele, can you please summarize for us what was the idea behind this study? And I must confess that I was aware that outside clinical trial, many groups were using letermovir off-label beyond day 100. So can you please clarify what was the idea behind running the study and what were the goals? And then we'll go into details into the different points raised by Antoine.
Okay. Yes, the idea was that even after day 100, we have patients who can experience very severe CMV reactivations. So even though we know that CMV is an herpes virus, so we will never get rid of CMV and we have to live our life with CMV, there are certain patients who can still die or experience life-threatening complications for CMV even after day 100. So the point was to reduce this burden of problems for high-risk patients. Okay, this was the first objective and idea behind the study. To be honest, I partially agree with what Antoine said, and in particular, also, if I look at the Italian population of transplanted patients, actually, 99% of these patients can be enrolled in such a trial because of high risk feature after day 100. So in daily life, I would be a little bit more restrictive in really thinking which are the most relevant high risk factors after day 100. So, for example, acute GVHD under steroids, to my point of view, is really more important than having received an apple transplant or a mismatched transplant 150 days before. So this will be something that should be addressed in clinical practice.
Excellent. Thank you very much, Michele. And you brought an important highlight about patient selection and who is eligible and who cannot be. And by the way, guys, as usual, you know, the Journal Club is an interactive activity. It is live. So please don't hesitate to post your questions or make comments, and I'll do my best to share them with the panelists. So Antoine, before talking about the price, about the efficacy, the relevance of the primary endpoint, and what would be the ideal endpoint, what was your thought about the safety and feasibility, actually, of this extended approach of administering letermovir?
When I read this paper, I can say that it's really well tolerated, but we already know that because personally I use it for patients with acute GVHD disease under steroids, and I can say that it's really well tolerated. There is one point, it's about the risk of relapse. In that study, there were no significant difference, but we have to be cautious if we want to extend for a long time letermovir. We have to look really closely to the incidence of relapse, I think. But basically, in that study, it was really well tolerated, and it's like in practice.
So in terms of safety, it confirmed what we already know about the use of letermovir. So Michele, let's speak a little bit about the primary endpoint and something that has been raised, whether having the cumulative rate of CMV infection is the ideal primary endpoint for such a trial, and what would have been the alternative?
This is a very important question, I think, because actually the incidence of CMV clinical significant infection as primary endpoint is the most appealing one. If we look at the other trials with other drugs, for example, maribavir, they failed the registration of the drug, the primary endpoint, because the authors chose the wrong endpoint, which was disease, CMV disease, or even mortality, which is even more difficult to address, you know, because we have very active drugs against CMV. So dying from CMV is, thanks God, quite difficult to nowadays. So the endpoint is quite, I mean, I can understand that this endpoint is really a good one because it's quite easy to reach. but in practice, maybe we are more attracted by other more complex endpoint. One idea to me is for example, the incidence of graft and relapse-free survival, which is a composite endpoint that is very useful, and it's not strictly CMV correlated, but it can be. So maybe this is something that we have to look at with longer follow-up of these patients.
So Antoine, same question to you. If you have to run this trial today, what you would have chosen as a primary endpoint, bearing in mind, and I need to be fair, that sometimes you need to find a pragmatic primary endpoint if you're looking for registration and to make a drug easily accessible. But I'm very eager to hear your thoughts about the ideal primary endpoint you would have chosen.
Yeah, it's difficult because if you are too restrictive, if you want to prove something in OS or end organ disease, it's difficult. You have to include a lot of patients. But using preemptive therapy with a threshold of 300 units per ml, maybe that's the problem. Maybe with a little bit higher threshold, maybe it will be more relevant, because after day 100, it's proven that there is a lot of blips. So we will treat a lot of blips with that cutoff, but it's difficult. There is no perfect response, I think.
Okay, wonderful. So we have here a question or sort of a mix of question and comment from Dr. Sayan Roy, highlighting that after day 100, there are late reactivations of CMV. So, and that would raise a question of cost effectiveness compared to preemptive therapy alone. What do you think, Michele, about this comment?
This is a good question. I think that if we imagine to prolong prophylaxis from day 200, 300, and then 300 and 400, we will always find the same shape of the figure. So, and if we don't let the immune system to face the CMV, the patients will never be able to control the CMV in his body. I think that the issue of the cost is important, and this is why I will basically base my treatment with prolonged prophylaxis on very high-risk patients, and I can add, for example, with no signs on specific CMV immune reconstitution, which is something that I start looking at after day 100 to select those patients for whom I need a strict monitoring of CMV DNA and maybe an extended prophylaxis. This is my idea.
No, thank you. And this is actually in line with a question we have from Dr. Teresa Pais, who is asking about whether actually it is relevant to extend letermovir, while we know if you allow time for the development of cytotoxic T lymphocyte against CMV, it may be sufficient. What's your take on this, Antoine?
I think that looking at CMV-specific immunity is really a good way. I think in the future, we will have to refine the population. Like Michele said, we have to treat longer, maybe more than 200 days for very high-risk patients, and looking at the immunity, the specific cell immunity, T-cell immunity, maybe combined with clinical parameters, maybe with the help of AI, we could refine the definition of very high-risk patients.
Excellent. Thank you so much. So let me open a little bit the debate. And obviously, I think both of you are in agreement about the limitations of this trial. But both of you, I think, are in agreement that CMV remains a matter of concern after transplant, but also beyond the transplant. So, and the question is for both of you, what do you think are today the unmet needs when it comes to management of CMV, whether prophylaxis, preemptive approach, or curative approach? Michele?
Okay. One of the most important unmet need, in my opinion, is the issue of anti-CMV specific immune reconstitution. This is something I really believe that can change our daily practice if we will be able to make it like a routine exam. You know, that there was an BMT survey, and on what centers are doing. Raffaella Greco collected that data some years ago, and they showed that it is coming into clinical practice, but if I remember well, not more than 40% of transplant centers in Europe use quantiferon CMV, ELISpot, or whatever to assess this issue. So this is, I think, something that we need to prospectively employ and use. And the other thing, I don't know if we move outside the transplant setting, I start to see some CMV reactivation also after CAR T-cell therapy, in particular for those patients who receive high-dose steroids for long period of time. And this is something that, I mean, it is important because we also know that these patients experience cytopenias after CAR T, and so CMV can worsen this cytopenia, and so they can become really challenging situations. So these are 2 points that needs to be investigated.
Antoine, what's your take on this?
Yes, I agree on the first point. It is really, really crucial to refine the definition of very high risk in the setting of transplantation or outside transplantation, with specific T-cell immunity in the routine. It will be really, really helpful. And yes, in the CAR T-cell setting, I don't see a lot of CMV during the cytopenias. It exists, but to me, it's not it's not really frequent. And when it's high, I treat it, but I don't know if it's really a problem.
Thank you very much. And we have a comment from Dr. Don Diamond about a so-called triplex vaccine that will be tested thanks to an IACH grant. So we're looking forward to see these results in the future. So here, we have another question, Michele, about the role and value of anti-CMV CTLs, because obviously you mentioned the role of the immune system in controlling CMV, and immune recovery is actually an important issue. And Dr. Kapp emphasized those population at high risk. And this is, for instance, if you're receiving high-dose ATG or T-cell depletion. So it goes in the same. So do you see a role for CTLs in these patients? Because obviously, you may be able to get rid of the burden of giving 6 months or 7 months of therapy with whatever drug.
Yeah, thank you. Thank you. This is another interesting point, and I think that there's a role for these CTLs. The problem is manufacturing, I think, because at least in Italy, it's not easy to have these lymphocytes if you don't produce them in a cell factor, which is not the case of my center and of the great majority of the transplant centers. So we have our colleague in Pavia, they produced the CMV Patrizia Comoli, and she published several data. So we found, we used them a couple of times in very resistant CMV infections, but obviously outside clinical trials. So I think that the problem is always that we need valid data from controlled clinical trials. This is my idea.
Thank you, Michele. Antoine, any thoughts on the use of T cells against CMV?
I don't have a lot of experience to treat refractory CMV disease with T cell specific therapy, but it could be useful in certain cases. I think if you use ganciclovir, foscavir, or maribavir, it will be rare, quite rare to have ultra-refractory CMV, but it exists.
No, I like this, and we need, although we were questioning the design of the study or the primary endpoint, but we have to emphasize that actually letermovir has really allowed for a significant advance and almost eradicated, I would say, the burden of treating CMV reactivations in our clinic. But Michele, you wanted to say something?
No, just I totally agree with Antoine, because I think that maribavir really changed the problem of refractory and resistant CMV infection. So now we have few CMV because of letermovir. We have very few CMV refractory and resistance, and then we have maribavir. And so I think that the problem of CTLs is something really difficult to develop in this period with the new drugs we have.
Okay, so I think you alluded, one of you alluded to the issue of resistant CMV. We have a question here from Professor Nagler, who's my co-chair at the IACH. Hello, Arnon. And he's asking about whether, Michele, in this study, you could see an increased risk of resistant strains in those patients who receive extended duration of letermovir.
My knowledge, this is not really a problem when you use letermovir during prophylaxis, because the genetic barrier of letermovir is very low if you use letermovir with a high burden of replicating CMV. But when you use letermovir in prophylaxis, actually you use it when the CMV viral load is undetectable or really very low. And this is not something that put the patient at risk of developing resistant strains. This is as far as I know.
Excellent, thank you very much. So let's broaden a little bit the discussion. And Michele, you alluded, for instance, to the risk of CMV reactivation after CAR T cells, but actually we started seeing a lot of viral reactivation, including CMV, for instance, outside transplant in the setting of bispecific antibodies, for instance, treating myeloma, for the anti-BCMA, the B-cell maturation antigen like teclistamab or irinotecan, are creating a profound status of immune suppression. And these patients, usually we give routine Ig immunoglobulins for prophylaxis. So Antoine, do you see a role of letermovir prophylaxis in this kind of high-risk populations?
It's really it's early to be sure, because there is no data as far as I know, but it could be. But once again, I think this problem is we can solve this problem with another way. We know T cell exhaustion with continuous exposition to the bispecific antibody. So maybe it will be more the change of paradigm, changing the schedules of bispecifics more than giving one drug one more drug. We will have more to do some treatment stopping, some rest for the T cells, and not adding another drug.
No, I think this is a very important piece of advice, and definitely, I think in the myeloma community, there's a lot of interest about trying to rethink the schedule and the duration of the cycles, and many colleagues are already actually extending the duration of cycles. Michele, any thoughts on this?
No, I agree with Antoine, and I want to put an accent on the role of CMV monitoring. This is really inexpensive because it's a PCR for CMV. It's nothing in comparison to treatment or even more prophylaxis. And usually in most of the centers in which B-specific antibodies are used, this exam is performed every day, and you have the result every other day or maybe every 2 days. So I think that it's too early to think about a prophylaxis in, for example, myeloma patients receiving B-specific, but maybe because with the tool of monitoring and sequential monitoring, you can really start very promptly an anti-CMV preemptive treatment in a patients for whom these drugs can be even better tolerated than in a transplanted patients in the first 100 days, maybe.
Wonderful, thank you. One last question to both of you, same question, because we've reached almost the end of this lovely journal club, lovely discussion and lots of questions from the audience, is where do you see the next steps? What would be the next frontier when it comes to the management of CMV in high-risk patients? What you would like to do tomorrow, Antoine?
I would like to address a question. It's in the allogenic transplantation setting, because we didn't spoke about abatacept, and the use of abatacept is increasing in the prophylaxis, in the GVHD disease prophylaxis, and we know that there is a quite high incidence of CMV infections for that population, and maybe it's a good population to treat with extended dose of letermovir. I don't know, it's a question.
Okay, no, that's good. And just to clarify for the audience, you're alluding actually because actually abatacept, although it's an old drug, has been approved a couple of years ago based on registry data for GVHD prophylaxis, although not very popular, but as you said, some teams are starting testing it. Michele, what are the next steps?
I don't want to seem repetitive, but it's something that I have really in my mind, and the issue of immune reconstitution. So we have to think some trials in which this tool is included and used to, for example, choose different way of proceeding with prophylaxis or management of our patients. So this is something that, to my knowledge, has never been included yet in any of these trials, maybe because they focus it on the first 100 days when it's too early to think about immune reconstitution, maybe. But we have to include this in a prospective trial.
Thank you very much. And actually, it's quite amazing the progress we have made and we have seen in the field of CMV management, because the most senior colleagues in the audience may remember that in the 80s and early 90s, a significant proportion of patients were dying of CMV disease and CMV pneumonia after transplant. And then the introduction of the preemptive treatment was a turning point. And now we're digging deeper and deeper. And I think letermovir has been an important advance in this field, and we will continue to progress. So thank you, Michele. Thank you, Antoine, for sharing your knowledge,
Thank you very
your
much.
Thank you.
analysis, and Thank you all for being loyal to the ICH and the Journal Club. And wherever you are, please stay safe and keep well. Take care. Bye.
Bye-bye.